A very good morning, friends. This video has two very interesting points. The first point is that I found that the anterior capsule was extremely thin, almost like a very thin cellophane paper. And the second important point is I would like to describe a simple and ideal way of how you can implant a Toric Trifocal plate haptic design intraocular lens within the capsular bag so that it aligns accurately with the axis of placement marks. This particular patient was just 21 years old. He had a small posterior subcapsular cataract. The best corrected visual acuity was 6/9. However, the patient complained of disabling glare in that eye. He had significant astigmatism of 2.5 diopters. The other eye was normal, and it was decided that we would take this patient up for a trifocal toric intraocular lens after suitable counseling of the patient. So to start with, the corneal epithelium is coated with HPMC to prevent it from drying. The anterior chamber is filled with a little amount of viscoelastic, and the clear corneal incision is fashioned. Remember that if you over-insufflate with viscoelastic substances, then you will tend to get a very short clear corneal incision. Therefore, slight under-insufflation will help you to get a long tunnel. Now comes the interesting part. I would like you to note how the anterior capsule behaves when I am performing capsulorhexis. I start the capsulorhexis in the usual point, and although I am trying to raise a flap, it looks as though there is no flap at all. The anterior capsule, once it is toned and the edge of the rhexis is extended, is all crumpled at one point, and we don't see the usual triangular flap formation. It's as though the anterior capsule is made of cellophane paper, and the whole capsule, which is elastic and under some considerable amount of tension, simply crumples up at one point. So I was really confused at this point. Was it that the flap was turned inwards rather than outwards? So I tried again. I'm trying to elevate the flap, but even after having completed almost 3 clock hours of the capsulorhexis, there is no trail of a fold of the capsule, which we generally tend to see. The entire capsule is simply crumpled up at one point. So in this manner, the anterior capsule is almost behaving like a posterior capsule. It is a kind of feel that you get when you're doing a posterior capsulorhexis. Extremely thin anterior capsule, and therefore I decide that the best way forward in this case is to use a Unamura forceps to complete the capsulorhexis. So holding on to the tearing edge, I gently maneuver the edge of the capsulorhexis in a circular fashion, and you'll be surprised to see that at the end of capsulorhexis, the residual fold of capsule is just a small crumpled shell, which I pull out of the eye. Well, the rest of the procedure is quite simple because this is an extremely soft cataract, and I perform hydro procedures, cortical cleavage hydrodissection and hydrodelineation, and I know that I can simply remove this soft lens matter with simple aspiration alone, going in with my phaco probe in the epinucleus mode. Well, the reason for presenting in this case is the abnormal behavior of the anterior capsule. Unless you're mindful of this, if you encounter an anterior capsule of this consistency, you may get pretty confused. So the soft lens matter is simply aspirated. and the cortex is also washed out. You will note that this is a toric lens. I have placed the toric marks with the help of a hockey stick blade, both the side of incision marks and the axis of placement marks. The incision which I took was bisecting the incision mark made by the hockey stick blade. After thoroughly washing off all the cortex, making sure that no residual cortex is left behind, I am getting ready to implant the Toric Trifocal intraocular lens. And before that, I enhance the visibility of marks with a little amount of blue ink which I get from a marker pen. I leach it onto the marks and then I wash it off to leave a thin mark. Now this is a Blue Mix 180 injector system that takes the Zeiss trifocal toric lens. It is a preloaded lens and it's quite simple to maneuver as long as you watch the video of how to manipulate this design or Blue Mix design of injector system before you implant the lens. The system can be injected through a 2.2 mm incision. Now a Zeiss trifocal lens have a central hydrophilic core and an outer hydrophobic covering. So this makes the lens extremely thin and pliable. I inject only the inferior haptic into the capsular bag. Then there is a convenient hole at the haptic optic junction. Now using this hole and using a Sinskey hook, I am able to maneuver it. The trailing haptic is above the capsular bag while maneuvering it to the desired location, after which you can simply press it down into the capsular bag. This lens being very thin and flexible will easily go into the capsular bag. Now this is probably the best way of getting the alignment, because if you inject the entire lens within the capsular bag, then the rotation of this lens is going to be a little difficult. Also, pivot rotation does not work well in this particular lens because it's thin and flexible, and so I find that I'm not able to pivot rotate this lens easily as well. So this is probably in my hands the best way of getting the suitable alignment. Of course, the viscoelastic is completely washed off and the alignment is checked by making sure that the two reflexes on the cornea, the Hirschberg reflex or the Purkinje 1 image and the combined Purkinje 3 and 4 images that come from the lens, are all aligned in one straight plane, along with the radial marks on the toric lens and the radial marks on the cornea. So the purpose of making this video was to make you aware of the two important things in this video. Firstly, the thin anterior capsule and how to manage it, and secondly, a simple way of implanting a plate haptic design of a Toric trifocal intraocular lens. Post-operatively, this patient did extremely well. He had an unaided visual acuity of 6/6 for distance and a near visual acuity of n/6. His residual astigmatism was minus 0.25 diopters, and under the slit lamp, when the slit beam was aligned to the axis of placement, it was found that he had a spot-on alignment of the toric intraocular lens. Thank you for your attention.